This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Welcome to another episode of It's Not In Your Head. I'm Justine Feidelson here with my co-host, Dr. Dan Bates. And today we're going to be diving into neuropathic pain. If you were with us on the last episode, we got into nociceptive pain and the different aspects of diagnosing that, treating it, what living with it is like as a patient, different challenges that Dan faces as a provider. And neuropathic pain can also be very difficult to treat, diagnose, address well, but in some ways it can actually be a bit simpler and more straightforward depending on the diagnosis compared to nociceptive pain. Dan, how do you kind of look at neuropathic pain in comparison and approach treating patients who present with this primarily when they walk in your door?
Yeah. Okay. So neuropathic pain is, so you got to ask about like, where is it? What does it feel like? What are its features? And so basically neuropathic pain will locate itself in the distribution of the nerve or the nerve root or the spinal or brain area that is affected. So you'll get peripheral pain, you get pain in the distribution of a nerve root. And as you get further up, the pain will get more diffuse. It tends to have this waxing and waning type of presentation. So some days it's better, some days it's worse. And it gets this intermittent spikes that come along with it. A lot of the time it's random. And one of the main questions I'll ask patients is, well, what makes it worse? They'll say nothing. And I'll go, well, is it random? And they'll go, yeah, it's like random, just comes out of nowhere. Right. It can be sitting on the couch, just gets sore. The thing about it is that what does it actually feel like? So it's generally burning, pins and needles, numbness, itching, crawling, painful cold, painful squeezing, and then a bunch of other weird symptoms. So things like I can feel water running down my leg or things along those lines where it just kind of doesn't make sense. That's kind of what I look for. The thing that's slightly different with neuropathic pain is that with nociceptive pain, the features are quite useful. You know, it's inflammatory, it's myofascial, it's
gives you
mechanical.
Information. Right.
Yeah, with neuropathic pain, like it's not so useful breaking it down. Like, you got to recognize it.
Right.
But other than recognizing, you know, that it's present, there's not much that really allows you, okay, well, now I'm going to do this.
Right. It's not based upon the type of symptom, like burning, do this, squeezing, do this, crawling, do this. Yeah.
Yeah. Except for maybe cold hyperalgesia. So cold hyperalgesia is when you have this painful cold area. And it's not, I get pain when it's cold. It's actually cold that feels painful, which is slightly different. Mm-hmm. But if you've got it, you know what it is effectively. Right. And so with that, you can use duloxetine. It's also called Cymbalta. That probably has some increased efficacy within, you know, that type of pain. But outside of that, there's not really anything, at least for me, that directs my therapeutic choices.
Yeah, that makes sense.
So then the question is, what causes it? So neuropathic pain will be either caused by a nerve injury or it's going to be caused by nerve dysfunction. And so the nerve injury is kind of simple stuff, like you hit it, you know, you hit your funny bone. Okay, that's hitting a nerve, that's hitting your ulnar nerve. But if you then go on and damage it, you then go on and get a bunch of other symptoms that go with it. You might have a nerve root compression because you get a disc protrusion. So you get a disc protrusion, it pushes on the nerve, and that gives you pain that will then go down your leg or down your arm. If you get pain that is more central, if someone's had a stroke, you can then get post-stroke pain. And unfortunately, because most strokes will take place within the brain, that'll affect maybe the entire side of one person's body. And so you get this whole one-sided neuropathic pain.
Symptoms.
Other things that will cause it, so you might get metabolic disturbances. So like nutritional deficiencies like B12 deficiency will cause neuropathic pain. Diabetes over time, type 1 and type 2 will result in neuropathic pain, and it's one of the major presentations. Generally starts in feet, but can also start early in hands, and so that will you'll see symptoms there. You have other infective causes like herpes simplex virus when you're older will give you some nerve pain. Herpes zoster as you're older will give you shingles. Herpes zoster is the chickenpox virus. So we all, well, maybe not these days if you're a kid, but if you're a
I
kid, you
haven't had
probably shouldn't be listening to this podcast. You should be
Yeah.
doing something that's more fun. But chickenpox will then, after it's treated, after you've had it as a child, it then lives in your nervous system and within your nerve roots. And as you're older and you become immunosuppressed, it comes out as shingles. And so that's an infective version of it. And then you can have autoimmune disorders. So things like multiple sclerosis, autoimmune disorder, and it will also present with neuropathic pain. And then there's a plethora of other things that will present with neuropathic pain. One of the things that I noticed, most is we miss diagnosing neuropathic pain. And it's not because it's hard to diagnose, it's just because we don't ask.
Right.
And so, although I reckon I'm seeing it less, previously I'd have a lot of patients referred that you just go, well, what does it feel like? Oh, it's burning. Okay. It's got pins and needles in the area. And I got these spiders that run across it all the time. Okay, well, it's neuropathic. But, 5 years of pain, never been asked. And like that sort of stuff, you just got to ask.
Right.
And so I don't think it's overly difficult to diagnose, particularly when it's got those features. Now, one of the other components of neuropathic pain, it kind of gives you this deep gnawing ache. If you've got the deep gnawing ache, that overlaps with nociceptive pain. And so now it starts to get a bit confusing.
And this is part of where my back pain diagnosis was confusing, right? It's that neuropathic pain element, but for me it wasn't burning, crawling. I wasn't describing it like typical neuropathic pain. I was describing it like myofascial inflammatory nociceptive pain. So yeah, we'll get to that in the challenges section, but it's a really good point.
Yeah.
So how, Dan, would you kind of explain the differences between how nociceptive pain typically presents in people and how then these neuropathic elements can start to accrue given the complexities of either some pathologies versus more individual nerve injuries?
There's two components to that question, I reckon. So you sort of described two things. Firstly, the patient with nociceptive pain, so body part pain, that then has neuropathic features on top. And I think that that's where we're starting to see that amplification taking place within the system. You start seeing other symptoms, and then looking at the difference between body part pain or nociceptive pain and neuropathic pain. And so for nociceptive pain, which is body part, comes from body parts, it tends to be focal and it tends to be intermittent, with probably the two main things. When you look at that when comparison to neuropathic pain is in the distribution of a nerve. Now, if it's in the very distal end of the nerve that you capture it, it'll be actually in a relatively focal area. And it's great. You can get a patient to draw a pain diagram and you'll go, oh yeah, that's superficial perineal nerve entrapment, easy. Alternatively, it'll be a compression in a nerve root. And so something like, L5, you could be looking to see whether they've got pain going down to a toe. So it'll go down the back of their leg, outside part of the calf, and then does it go to the big toe? Does it go to the little toe? So then you think about S1. Is it going to the sole of the foot? You're thinking about, once again, S1. If it's going to their shin, in that setting where you're starting to think of, it's an L4 nerve root here, or is it going to the inside part of the knee? Okay, well now you're thinking about L3, but different to a nociceptive pain or body part pain, it's like you're taking in an entire leg with the pain ending up in different spots rather than it just being like in an area this big, which is what we normally see with nociceptive pain. Then, as we just discussed before, the features in body part pain are probably more useful for helping you guide what you're going to do with it from a therapeutic perspective. The neuropathic pain features, we don't have good therapies that, we go, okay, you've got pins and needles, I'm going to do this, or you've got numbness, you're going to do that. One of the things that does happen with neuropathic pain is different bits go away when you treat them early. So let's say we're talking about a nerve root compression. What you'll find with a nerve root compression is that you can treat the pain, that'll go away relatively early, and being really what the main target is. The pins and needles will also go away, but the numbness may take a long time for it to resolve. And so,
Yeah.
you know, and what will happen with that is like a C7 nerve recompression, they're really quite, I like treating them because, you know, if you've got a disc bulge, you don't have a significant amount of weakness, but you might have some numbness that's not progressing. The disc will retract over time. And so you can treat them with some epidurals, you can treat them with medications, you can get the patient along as the disc retracts over time. And so people early get a decrease in their pain, they get a decrease in their pins and needles, but the numbness will just slowly but surely go. And I'll have patients come back even like a couple of years later and they have just numbness still over the tips of their fingers because it hasn't completely resolved. But they will have started with
Right.
numbness over in like a big
Right.
area. And so
Yeah.
it's the last thing always to go. The other thing with neuropathic, the differences between nociceptive and neuropathic pain is, at least from my experience, is the emotional component. So body part pain, when it's early in the piece, it does make you cry. Like, and I think like everyone will go, everyone's seen that, you know, you can break an arm or dislocate something and it hurts like hell. There's no doubting that it hurts, but it doesn't really make people cry that much. It's sort of like, but no
Right.
one bursts into tears.
Yeah.
Neuropathic pain, neuropathic pain makes you cry.
Right.
Like, and I have seen, like, I've had a number of patients over the years, just older, particularly older blokes that have been stalwarts their entire life, haven't shed a tear since the age of 3. And they come in and they'll have neuropathic pain and they'll go, Dan, why does this make me cry? Like, I haven't cried forever. What's going on? And what's going on there is that when you look at pain, there's multiple components of the spinal cord and brain that are involved, but you can kind of split them into two pathways. One pathway is referred to as the lateral pathway, and that's the pathway that gives you the ouch is kind of the way you can think about it. And the medial pathway, which goes to the emotional components of the brain, gives you, not surprisingly, the emotional component of the pain. And I think that when you have body part pain, you have dominantly pain going to the ouch region, and that gives you obviously the painful sensation. With neuropathic pain, you get both. So you get both the ouch and you get more overlay of the emotional component, and it is very emotionally distressing.
Yeah. This is Dan's theory on this, and I'm sure that there's a part of it that is probably related to this. And the thing that I think is interesting with why do people cry compared to with neuropathic pain is the emotional component of having symptoms that are inexplicable, very bizarre, very intense, poorly understood or validated, and there's no end in sight. And it's quite distressing compared to my stuff is sore and achy, like cry me a river. I've lived with certain types of myofascial pain compared to certain types of neuropathic pain. Neuropathic pain, whether it's isolated or in the context of other emotional amplifiers or things that are making that neuropathic pain such a bigger crisis to how that person is perceiving it, I think also plays a role in why is neuropathic pain such a intense experience for the patient compared to equally long-standing, equally frustrating, to be fair, other things that haven't, maybe been diagnosed, but are they less intrusive? I don't know.
I agree and I disagree. Like, I agree. I think that you can have a nociceptive pain that goes for long enough that you generate the same senses of helplessness
Right.
and
But we're not
and
saying
the
nociceptive
same
pain can't make
losses.
you cry.
No, no,
Right.
no, no. But I'm just sort of, from my perspective, the reason why I sort of see it from the physiological perspective is that you see it in the short term. You see that the emotional component with the patient becomes dominant, like really early in the piece. We're not talking 5 years of neuropathic pain. We're talking like 5 weeks of neuropathic pain. And I think it's, for me, I've seen it as different, but I agree. It doesn't matter. Like
Yeah.
the helplessness, the hopelessness, this thing is never ending is like,
It's also more like weird and annoying and awful, I think, in some ways compared to, yeah, it's not that it's impossible to treat, but it's very bizarre and it's in quite a contrast to what you're used to feeling. Whereas your whole life, if you've been active or you've had injuries, you've been exposed to what that feels like. But it can be quite a contrast to have neuropathic pain. So yeah, it's just
yeah, I think there's no doubt that it's probably more awful than straight nociceptive pain.
from a treatment perspective, Dan, how do you approach the different types of neuropathic pain, or do you have different approaches based upon if it's more of a syndrome pathology, a type of context versus more of a procedural block the nerve that's calling out?
So in 2019, we wrote a paper, a bunch of colleagues of mine and myself. It's called the Comprehensive Algorithm for the Management of Neuropathic Pain. That was like hilarious watching you guys like.
Everyone's favorite trick is when I make the desk higher or lower. For all of those watching us on YouTube, you'll know what we're talking about.
Anyway, so yes, so what we did with this algorithm is we brought together all the international guidelines of how to go about and manage neuropathic pain and put it into effectively a single algorithm that you could look at it on an A4 page. Because what I was getting frustrated with at the time is that I'd have patients that would come in, they'd been put on to generally pregabalin, which is Lyrica, and left on it. And they'd been left on it for like years.
Ever.
And so then getting them off becomes really difficult, and you've got all the other side effects that go with it. But
it's a very high side effect, med for a lot of people too.
And so what we did is we wrote this paper that's just essentially based on how do you assess the presence of neuropathic pain. And for me, that was addressing the problem of nobody asked the question. Have you got any burning, pins and needles, or numbness? Like, it's not that hard to ask.
No, these are even easier, I think, to pull out than other symptoms of pain because they're so odd. So
And there's other weirder symptoms like the constriction feeling, like the tight band that's pressure, around thing. That thing's most people don't know how to describe that, and so you've got to ask for it as well. And the other thing that people won't do is people won't tell you about the spiders that they feel running across their leg because they think that they're crazy and they don't want to tell you. So you got to ask whether it's there. So anyway, so the assessment component is that we generate a set of standard outcome measures to then go, okay, well, this makes it more likely it's nociceptive or more likely it's neuropathic. And look, we can link to those, like they're all freely available on the internet, and it gives you a bit of an idea about how you can then start to tease out what type of pain you might have. Then we split that algorithm into first line, second line, third line, fourth line, something along those lines. And so first line therapy is then looking at medications. And so when we were writing this, we were targeting it really at the family practitioner type level, the person that is going to be seeing people the first time they walk through the door. And so you're going to be looking at all the conservative measures, so involving your psychologist, doing your rehab, all that sort of stuff. But the main measures I'll work through here is like me when I'm thinking about what I'm going to be teaching like a family practitioner or a general practitioner in Australia. And so first line is medications. And so there's 4 main medications that we use for neuropathic pain. First one's amitriptyline, second one's duloxetine, third one is gabapentin, and the fourth one is pregabalin, which is Lyrica.
Yeah.
And then the other option there is to then look at topicals. And so how we lay this out is starting at amitriptyline first. And so the important thing to recognize here is we laid it out in this fashion based on the number needed to treat. So the number needed to treat is the number of people I need to treat to get an improvement in somebody's pain of 30 to 50% when compared to a placebo, to another treatment. Okay. And so if you look at that, the number needed to treat when you use amitriptyline is 3.6. When you look at duloxetine, it's 6.4. Wow. And for gabapentin and Lyrica, it's 8.
And it's funny because these are all the hallmark CRPS drugs that you
Yeah,
cycle
yeah, yeah.
through, for example, with
Yeah. And
neuropathic
so,
pain. So, yeah.
and the important point there is that you need to flip those numbers. Okay. So if you look at the proportion of people that will do better with amitriptyline, so the number needed to treat is 3.6. So realistically, that's 4.
Right.
And one of those 4 is going to get a 30% to 50%. And let's be honest, not 50,
Right.
it's 30. It's a
Yeah,
30% decrease in pain, and the other 3 won't.
will
So
not.
that means it only works in
1 in 4
25,
people. Yeah. Yes.
25% of patients. And then you look at duloxetine, it works in about 13% of patients. And you look at gabapentin and Lyrica, they work in 11% of patients.
Yeah. And this is
And
huge.
so
Yeah.
if you don't get a good response to those medications, that actually just makes you normal. Like the
Right.
patients that respond to these medications, it's like you're
They're
the outlier.
Exactly.
Like be thankful you're the outlier, but you're
Right.
the outlier. And
Patients don't really realize this, Dan. I think a lot of patients feel that medications are supposed to work for them. And it's frustrating or confusing, or they don't understand even that it's unlikely. Or if it does, thank goodness, but it's not even 50-50.
yeah, I think that the way I sort of see it is that I want this to work for you,
Right.
but it's not likely to work for you. And you know what? From time to time, like 1 in every 8 generally, I'll have that patient that comes in that has been on pregabalin and they knock it out of the park.
Right. Hits it out of the park. Low side effect, huge.
Low side effects.
Beautiful.
Yeah.
Yeah. Awesome.
Like, great. That's the one you use it for.
And this is why they're
And
always worth trying. Try them, right? At least so you can see, because maybe you won't be high side effect. Maybe you won't be the less likely.
yeah.
But
And this is the key, and this is kind of the key within the algorithm, is that what you want to do is the recommendation, and the recommendation across all the international guidelines is you trial these for 4 to 6 weeks. So start at amitriptyline, give it 4 to 6 weeks. Start it, then go, it doesn't work, go to duloxetine. Next one, go to gabapentin or go to pregabalin. You know, I was doing a talk last week to a group of rehab physicians, and they sort of asked, well, Dan, I just started Lyrica. And I'm like, well, the likelihood that Lyrica is going to work with comparison to amitriptyline is half. You have to treat twice as many people to get the same response. So why start at Lyrica? Start at amitriptyline.
Right.
There's a couple of other things that I'll do within that. And so if you've got someone who's come in and like they've never had any antineuropathics and not on any other drug, sure, go like amitriptyline to pregabalin. However, very rarely does anybody walk through the door and not actually be on something else already. And so I then apply a clinical overlay on top of what's a logical overlay, which is then the thing with amitriptyline is amitriptyline improves sleep. And so if I've got somebody who's really struggling with their sleep, I'm probably going to start them on amitriptyline first.
Right.
Now, for many patients, they're really sensitive to it. So you start at 1 tablet, which is 10 milligrams, it knocks their socks off and they never take it again. So even though you're not supposed to, what I do is I encourage people to take a quarter of a tablet. And we go up by about a quarter per week. And so my patients go up by a quarter per week until they find a level that it works. When you get over 25 milligrams, though, over 25 milligrams, it loses its pain relieving benefit. And so
piling on side effects.
Once you get to 25, if it hasn't worked, probably not going to work.
Right.
Like, get rid of it.
Move on. Yeah.
Yeah. And so if you can't sleep, amitriptyline. Now, if the patient is really depressed, then the next option in that is then duloxetine. And so if I have a patient that, you know, no sleep disturbance issues, but they've got mood disturbance issues, what I'm probably going to choose duloxetine is where I start within the algorithm, because I might get benefits from a mood perspective, plus I'm going to get benefits.
The pain as well.
From a pain perspective. And then I avoid like the gabapentinoids, so gabapentin and pregabalin as much as I can.
Yeah.
But if you're already on amitriptyline, you're already on another antidepressant, I'm sort of running out of options. And so that's when, okay, I'll go with one of the gabapentinoids when they're already on other stuff and I can't mix them. So that's kind of where my clinical algorithm goes. So can't sleep, amitriptyline, SAD, or really anxious, duloxetine, already on something else, let's try gabapentin and pregabalin.
Right.
But my approach is I tend to start with gabapentin first, not because the data is a little bit better for efficacy around with the use of pregabalin, and certainly its dosing regime. There's a more linear line when you dose somebody that they get more direct response to pain if they're going to respond. But gabapentin's easy to get people off. And so I run with the fact that this works in 11% of patients. Most likely I'm going to have to get you off this.
Right.
So I'm going to go with what's going to be easier to take somebody off. And for me, I find it easier to take people off gabapentin than I do to take them off Lyrica. Now, that said, if you had Lyrica at a relatively low dose and it's 12 months, okay, that's pretty easy to get off still. If you've had pregabalin for 300 milligrams twice a day and you've been on it for 3 to 5 years, okay, it's a bit more of a challenge to get off. And I think that takes, it takes a lot more of an effort to get through.
Is gabapentin lower side effect, do you feel, in your patients, Dan? Because I feel like in America, it really depends with gabapentin. It can be so benign compared to Cymbalta and Lyrica, but some people it will impact enormously from a depression like perspective too. Okay, so you don't really find
and I think that's where you've got to go. You've got to go. This should have a 4 to 6 week trial. If it hasn't worked, get off it.
Yeah.
If during that period of time you've got a bunch of side effects that do not match the benefit.
Right. They are more negatively impacting your ability to manage pain than the upside provides. And a lot of patients and sometimes even providers don't reassess that at different points down the line. When if your pain's better, do you still have to be on the same height of that medication maybe, right? And a lot of times, like you said, people just get left on it, like on gabapentin just forever. Does
this make any difference? Don't know.
Yeah.
Okay.
At that point then, yeah.
You need to really be getting people off if they've got a ton of side effects or if the thing doesn't work. The last component within that first line of therapy is then topical medications. And so topical medications have got a relatively limited amount of evidence around their use. However, you can have them compounded and you can mix a number of different things together. And that's what I do with a number of therapeutic options. And so for the patient that has got that focal neuropathic pain that's this big, then you can rub a cream on
it. Yeah.
Awesome. Like rub a cream on it, see if you can turn it off with that, rather than having to take the medication that has side effects across the entirety of your body.
Right.
You can get away with treating it in a local area. Right. And once again, you know what? I think number needed to treat for your topicals is probably closer to 9 rather than 8.
Yeah.
But the side effect profile is so low, and the efficacy for some people, it's worth trying.
Right.
But once again, if it doesn't work, chuck it out. And where people don't get a large amount of like systemic side effects, so they don't get the nauseas and the brain fogs and all the stuff you can get with the side effects of oral medications, they get rashes. And the rash can just come out of nowhere all of a sudden. So like, I got a rash. It was working really good, but now I got this big red spot. And you're like, okay, well, that's the end of that. Let's move on to next. And then interestingly, so what ends up being next is then a combination of those medications.
Right.
So
then you get the medications after you've exhausted
you try the duloxetine and you get a bitter response. All right, you've got minimal side effects. Great. Okay, then we add in some Lyrica or gabapentin. And so there's a number of studies that have looked at particularly that combination of Lyrica, pregabalin, and duloxetine, and they show that they're more effective than either of them alone. And they have different mechanisms of action, and it makes sense. And so I think it's very reasonable to start with one, add in a second if you get a partial response. And let's be honest, most people are going to get a partial response. And I think the numbers are something in the range of 80% of people are on at least 2 medications when you've got neuropathic pain. So
because the way pain works, it's very hard, with one medication to address all the reasons you have pain, or most of the drivers even. So you may knock off a big one, but you'll still have something left to deal with.
Yeah. And so the step after that is if you are unfortunately normal and you're within that majority of people that don't respond to medications, or more the point, and those that the majority of people that don't tolerate the medications.
Yeah.
Well, then you're looking at then what interventional options have you got? And so there's a range of interventional options with neuropathic pain that you can look at. They include local injections about nerves. They include injections around nerve roots, and include procedures such as pulsed radiofrequency. We do a reasonable amount of pulsed radiofrequency in Australia. You don't see it very much in the US. And what you're trying to do in this setting is you're trying to settle down how irritated the nerve is. A good way to think about this is in the setting of something like a nerve root compression by a disc. So what you've got in that setting, you've got two major things going on. You've got a disc protrusion that is pushing on a nerve. Now, a lot of the time, nerves don't care if you push on them. They care if they're pushed on and they're irritated. And so when you go on to do an epidural in that setting, what you're doing is you're putting in some local anesthetic, you're putting in some cortisone around the nerve, and you're trying to affect the irritation of the nerve. You're not making any difference to the mechanical compression.
Right.
But you can see plenty of MRIs where you've got nerve root compression, but it's on the other side of the pain. And so clearly the nerve doesn't care, but the nerve's not irritated. So epidurals are about taking out the irritation around the nerve.
Right.
Similarly, you can use pulsed radiofrequency in that setting. So pulsed radiofrequency is a different technique. It's where you take a needle, you place it next to the nerve, and you create a radiofrequency field around the nerve. And what it does, it triggers off gene translation or gene transcription, which then gets translated into the formation of anti-inflammatory cytokines. And so you get, once again, a decrease in the irritation of the nerve in response to, your therapeutic intervention. And so, and there's a range of other things that sit in there. If people have got epidural adhesions, there's adhesiolysis, there's numerous things. But at the end of the day, most of the time, what you're doing with any interventional technique is you're looking to try and settle down how irritated the nerve is. The step after that is then stepping into neuromodulation. There's a number of different types of neuromodulation. So neuromodulation is where you use essentially electricity to interrupt the signal going from the nerve up to somebody's brain, and where you place the leads will then define what we call it. So if you put the leads out in somebody's leg, arm, hand, it's in the periphery. So we call it peripheral nerve stimulation. When you place the leads next to somebody's nerve root, that's called the dorsal root ganglion, we call it dorsal root ganglion stimulation, and Juz has got one of those.
Yours truly.
When you place the leads next to the spinal cord, it's called spinal cord stimulation. And then if you place the leads up into somebody's brain, it's called deep brain stimulation. So it's not like
same
anybody
technology where you place it is what is effectively the difference.
Yeah. And so neuromodulation is effectively about interrupting the signal going from where the pain's being generated up to the brain where it's being perceived. And so that comes in at, I think it's fourth line treatment.
It's kind of the last house on the block option is what I tell people.
Interestingly, within this algorithm, if you look at what the UK guidelines were, the UK guidelines were if you have persistent neuropathic pain that is non-responsive to therapy for greater than 6 months,
right,
you should consider a trial of neuromodulation. And what we do with neuromodulation is we test it first. It's kind of one of the good things about STIM.
It's really nice.
There's a bunch of bad things about STIM. There's a bunch of good things about STIM. The one thing that's good about STIM is you get to try before you buy. So put the leads in, you see if it works. If it works, okay, great. You can then make some decisions around whether that level of pain relief is enough to justify putting leads in, managing a battery,
the invasiveness of the procedure and the downsides of living with it better be worth it.
Yeah. So that's one of the good bits. So, and then within that, you want to have a minimum of a 50% improvement in pain. For me, I personally want 80% improvement in pain. If you get 50% improvement, what I tend to find happens is that by the time you get 12 months down the track, you get some creep in the therapy, and you get a creep in like the patient's perception of the pain. So that 50% now becomes 90%, and now we're back to where we were. But if you can achieve 80% or more pain relief during a trial, like the effect seems to be better longer term. So I'm always looking for 80% plus.
Do you take into account, Dan, the syndrome or the pathology that you're trying to teach or treat with that rather? Because again, in a context like CRPS, for example, where there's a lot of things driving that output of what's being perceived as pain, to expect someone to even get 80%, it's pretty unusual because of how much the stimulation.
So within the discussion of, within like a trial period, what I'll be looking for people to do is not only do it's not just about how much, did it go from a 8 to a 4? Yeah.
Right. Too wide or too crude.
That's not, that's good, but that's not it. So what I also want to know is
specific symptoms.
Did you decrease your medications? Yes.
Yeah.
Did you get the opportunity to go out to dinner? Did you go walking with your partner? Did you sleep better? Did you,
variable?
It's not just about that 50% decrease in pain. And I think we're talking, at this point in time, we're talking about definitions within guidelines, and sort of, the definition is 50% decrease in pain is a positive trial. Right. But, where are we really? What do you want to see? What do you want to see is you want to see during a trial period an improvement in pain, but also maybe you want to see an improvement in their functional gain. You want to see that, hey, I stopped taking my tapentadol. Right. Though I didn't do this. I went out to dinner. Hey, I was able to do some gardening, and I didn't blow up in a massive ball of pain for 2 days afterwards. And so
changes, compound over time too, then, and can improve then the efficacy of the therapy. Whereas in that 1 week trial, you won't get the benefits of all those things yet. But if they exist because of the therapy, then the therapy will be even more effective. Yeah.
And so if that's what I'm looking for, there's times when I've had conversations with, third-party providers, so work cover providers that will fund this, that they've been, you know what, Dan, we see you only got a 30% decrease, but his functional gains were massive. Right. He's gone from 5 minutes to walking for an hour and a half.
Way more active, right?
You know what? Let's give him a go. And sometimes the insurers are actually you know what, the functional gain is massive. Let's put it in and let's see how we go. Right. Okay. And so interesting, and you mentioned stims end of line. Well, where we sort of saw that stims should actually not be end of line.
Not the end of line.
And then what comes after stim is then you think about low dose opioids. If you notice up the top of this algorithm,
that's more
there was no opioids. We didn't need opioids anywhere between it's not first line, not second line, not third line.
Off the
Stim's fourth line. Okay.
Yeah.
Now let's think about some low dose opioids with the with the proviso that it's no greater than 90 milliequivalents per day, et cetera, et cetera. And I think that recognizing that we do recognize that opioids over time make pain worse. The mechanisms of opioid induced hyperalgesia are well documented, and yes, everyone gets short-term pain relief when you take it, but unfortunately, that's coupled with this gradual worsening over time. And undoubtedly, we'll talk about that in detail at some other day. And the last part in the algorithm is then looking at intrathecal therapies. So intrathecal therapies is where you place essentially a catheter into the sac that surrounds the spinal cord, and you then infuse microdoses of maybe an opioid, maybe clonidine, maybe a range of other medications. It's not something that I actually do, but it can be quite effective in certain circumstances. It's not on my list of things I do, though.
Ideally preferred options. My understanding of those situations is one of the upsides is that it does allow the patient to get a much smaller, correct me if I'm wrong on this, amount of medication, because it's
You're correct.
local there, right? Rather than orally having to, again, take it system wide. So if you're trying to negate potentially some of the really bad downsides to opiates, a little bit of that.
Yeah, it does, but you can still get the massive negative side effects of the opioids. So I've had a couple of patients that have had intrathecal therapies and they've been put in like pre the advances we've seen in neuromodulation. And so they had a lot of the side effects of the opioids, peripheral edema, weight gain, the immunosuppression. And we went, okay, what we're going to do is we're going to trial some spinal cord stimulation in you, and we're going to see if we can improve your symptoms. And so what we've been able to do for those patients, you put in a spinal cord stim, that helps their pain. They then drop their doses of morphine that they require via the pump. And that's got rid of the peripheral swelling and all that. And so you get those benefits, but, expensive way to go about doing it.
Is the goal to get someone off a pump in that case? Is that possible, do you find sometimes, Dan, or is it kind of just minimizing the side effects?
I reckon I don't see enough patients with pumps.
Yeah, I was just wondering. Yeah.
So I probably can't. I reckon we need to get a pump doc in.
Pump doc. Right. Pump doc.
And ask the pump doc what they find. But for me,
stay tuned for the episode with the pump doc.
I don't see enough pump patients.
That's a good treatment summary, though, of how you would go from most conservative, sort of least intrusive, to higher invasiveness, but also high efficacy, if that's the point that you're at. And yeah, as difficult as some of these technologies can be, thank goodness we have them, is how I feel too, right? Living with a DRG spinal cord stimulator. And I'm glad it exists despite the challenges with it.
One of the things that's hard is that, and I went through this, last week with a patient, in that you jump pretty quick from, we're going to try some medications, hasn't worked.
Yeah.
And when I say quick, these patients will have had pain for years. I think I said before, like the guidelines say 6 months of non-responsive neuropathic pain. And so that's nice, but the average period of time somebody has got pain before they go to neuromodulation is actually 14 years. So it's not like we're anywhere near like something like that. Right. And so like 6 months, like no. That's a rare. I reckon the earliest that I see patients go to a stim would be, 9 to 12 months, in the setting of probably most commonly complex regional pain syndrome.
I was going to say probably CRPS. Yeah.
Yeah.
There aren't other good treatment options either, right, in that context versus others. And so you do quickly. Yeah, it's not because the physician's throwing it out like candy always, or doesn't have many things to go through. It's just because you pretty quickly, yay or nay, and then that's where you're at. Yeah.
That's one of the challenges, where you've got someone who's had pain for quite a long time. They come in, you've done your medications, no problems. I can try some diagnostic blocks. I can try some sympathetic ganglion blocks. We can try some pulse radio frequency, and efficacy of these things, like when they work, great, but when, like, a lot of the time, just like the medications, they don't knock it out of the park. And so you make a big jump really quickly from, we can stick a couple of needles in, to, okay, now we're talking about putting in a device that has got leads and batteries and all that sort of stuff that comes along with it. So they're big jumps really, like, unfortunately, really quickly. There's not much in between at the moment.
I think that's actually really good to shed some light on, though, because I think from the outside, and even as a patient, it can be jarring. But this is why, because there's not a whole bunch of things in between, unfortunately. And if there were, you would be less at the stimulator.
Yeah, and I think that you've got to ask. Okay, so you got to then ask, what's the number needed to treat for neuromodulation? I'm pretty sure it's 2.
Well,
so you've got to get. I think I could probably confirm that, but at the end of the day, the number needed to treat to get a 50% decrease in pain from one patient is 2.
And you can try it.
And you get to try it.
So you know what.
So you know whether you're going to, whether you're more likely to be the one out of that 2. So, and I reckon that that's probably my experience of it. What we see that during a trial, if you select well, 90%. If you're selecting less well, 80% of patients will have a positive trial. So that's 50% or greater decrease in pain. Once people go to an implant, the numbers are 75% of patients get the same result as they did in the trial. Okay, and if you do the numbers on that, that actually comes down to about 50% of patients. So, that's an NNT of 2.
Yeah.
So it's worth trying, putting into context all the other issues that exist around neuromodulation, and we'll have a conversation about that on another podcast.
We will.
But it can be effective. So
whether it's a good or bad decision depends on all the other, I always tell my patients, variables and the other things you've tried, basically.
Yeah, and what neuromodulation is part of the toolkit. They don't change your isolation. They don't change your catastrophizing. They don't change your hypervigilance. What they change is they change the sensation of pain. And, we got to do a bunch of other stuff around it that, then changes the overall component of pain. But it's a tool.
Yeah. It's very well.
And if the painful sensation is the thing getting in the way of getting ahead, well, it's worth considering.
Yeah, that's what I tell people. It's the only tool that's shaved off 50% of my symptoms by itself. But what do you do with the rest of the 50%? So that's everything else we're going to be talking about.
Yeah, that's called a podcast.
What a segue. Before we wrap up this episode, though, I do just want to quickly touch on, within this setting, what are the unique challenges for a patient and for the provider? From a patient perspective, as somebody who's lived with, unfortunately, a couple different types of neuropathic pain, as far as I've had cluster headaches, trigeminal neuralgia, right, which is kind of a facial variety. Then I've had cluneal nerves freaking out in my back, which is part of my low back pain sensitization situation. And then I obviously also have complex regional pain syndrome, which is sort of I kind of joke that it's like neuropathy on steroids, as far as, yes, it's a neuropathic syndrome, but it's got a whole bunch of this other stuff that's fueling that response and the level of intensity that the patient feels. And part of what's hard in teasing all of these different things out was identifying the nerve or the neuropathic component. It took me a long time to get cluster headaches diagnosed. I went for years with doing every type of procedure on my back that we could think of, other than cluneal nerve blocks, which were what addressed, for me, at least temporarily, right, that signal. And then within the context of CRPS, what's tricky about it is a lot of these symptoms people don't even tease out from a diagnostic perspective of what's truly complex regional pain syndrome, what's neuropathic elements on top or around it, what's central sensitization related heightening. Is allodynia actually a CRPS symptom, or is it just the way people describe a neuropathic symptom? And so I know as a patient, if I'm not, I'm not on the side of diagnosing it, even explaining and putting words to what you're feeling and experiencing can be difficult. And if you are in these settings where it's not just a nerve alone, isolated, screaming out, it can be really hard to even say what you're feeling or how is it impacting you, which even I didn't do a great job of. And it's my job with my back pain, for example, because I felt it differently. Dan laughs at me, rude, because I felt it differently. And I was like, even I struggled.
Yeah. So. Okay. So I think we can probably tease that apart into a couple of different things. I think that difficulty with describing pain. So there's two components to that. Firstly, there's a knowledge base for the clinician. CRPS is common in feet and lower limbs. It's common post-surgery. Right. I've got a group of foot surgeons that refer to me, and they refer early. Hey, Dan, I think this one's got CRPS. Can you see him? And I'm like, no problems. Get him in the door, because the earlier I can treat it. But they recognize it. They recognize that this is disproportionate pain and they'll ask whether they've got, burning, pins and needles, weird stuff going on. And they'll go, this is probably CRPS. Let's treat it early. And I think it's those people that don't recognize that it's CRPS, and that's why a major challenge. And within that is, let's be honest, it's the blame on the patient. And this is where it's patient's just crazy. My operation's perfect.
That's beautiful. Yeah.
Beautiful surgical outcome. Yeah, but it still fucking hurts. It still hurts. So, and it's that piece. It's the unfortunate piece where, it's in their head. Well, no, it's not in their head. They've got a physiological process that's taking place within the nerve root that's then grossly amplifying this pain.
Right.
And I think that, there's knowledge base on the medical side. What happens with doctors, like with everyone else, is that when they don't know something, when they feel that they haven't got it right, they haven't won, they haven't conquered this injury for the patient, they feel bad about it, and they feel bad about themselves. And so the way they defend themselves is they blame somebody else. And so unfortunately, the person getting blamed in that situation is the patient. And so that's not the case. It's not in your head, which is also an awesome podcast name. And then the next piece is that what you described, which is, how do you describe the pain? That is really hard. And the reason why I can go, oh, nociceptive pain is blah, 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 and neuropathic pain is burning, pins and needles, numbness, itching, crawling, painful cold, painful squeezing. The reason why I have that together as an algorithm, or I can explain it, is because that's what I ask in my history.
Right.
When I take a history, I ask each one of those things, and I ask it again and again and again because I'm looking for it, because the patient doesn't know how to say it. And when we get into more talking about sensitization, one of the components of sensitization is brain fog. And so brain fog, so you've got a patient that comes in with terrible pain and they can't concentrate and they can't really remember and they can't think. And we're asking them to try and describe what their pain feels like. And I think that for me, I have a very prescriptive history, and that I will try and draw these symptoms out of the patient to get an understanding of, do they have this or don't they have this? And it's that is me dealing with the patient's inability to describe the pain. And everyone says to me, Dan, I can't, it's really hard to describe. And my response every time is, that's okay. That's my job to work it out. You don't have to be able to describe it. You haven't done, stupid number of degrees and spent, 10 years sitting in front of patients just doing pain all the time. So that's my job to work out.
Are there any other limitations or challenges that you can think of, Dan? The only other one I can think of kind of from a diagnostic perspective is not just the physician's limitation themselves, but from a technical perspective, right? It's hard to identify nerve injuries and things of that nature. So, yeah.
So technologically, we get to the end of we get to our limits really quick. So MRIs are good at showing large lesions or large masses or things pushing on nerves or things in the middle of spinal cords or brains, but they don't show nerve dysfunction. They don't show nerve hypersensitivity. We can see swelling in areas when there's water there. So one of the ways that we look at a scan is we make water white. And so the theory being, where there's damage, there's swelling, where there's swelling, there's water. Great. Okay, go make the water white, go looking for it.
Right.
But inflammation is not all just about, the influx of water into an area, which is called edema.
Right.
There's multiple cytokine releases, and you can't see that on an MRI. And yes, we can do fancier MRIs, so we can do functional MRIs that will show brain changes, and you can get biomarkers of pain. But they get done, number one, they take ages to do. Number two, they get done only in very specialized, normally university settings.
Right.
And, if I was to refer for a functional MRI,
They would laugh at you.
to what's my usual MRI guys, they'll look at me and go, Dan,
right. Absolutely.
Serious?
Right.
Yeah, no, we won't do that, because that's going to take 2 hours, and it doesn't work. So the other limitation is then when you look at nerve conduction studies. So nerve conduction studies, notorious for false negatives. And so they're difficult to read. They're difficult to get positive results out of. And so the absence of a result on a nerve conduction study does not mean that there's not a nerve injury or a nerve dysfunction.
Right.
It just means the test was negative. And you might come back at a later point in time and the test will be positive. Okay.
This is like COVID testing early on. We're like, but the test might just not be right. Test it again.
Yeah. So nerve conduction studies, when they are positive, are really useful because it can then narrow down whether, there's a small fiber peripheral neuropathy, whether this is a focal injury or focal entrapment, whether this is a nerve root component to it. And so we do them on a regular basis because we're looking for the positive result. But if you get a negative result, okay.
Yeah.
Move on. Let's go. It's not next.
Yeah.
So it's about, balancing up what you're looking for out of an investigation.
Yeah, which is one of the ironies of CRPS being defined as type 1 and type 2 via nerve injury, when it's actually really hard to find and even be sure about how much of it is nerve related.
Yeah, and I think I was saying before, I think how much do I look specifically for a nerve injury? When it comes through the door and it's obvious someone's had like a, steel girder fall onto their arm. Okay, you've got a, you've got a nerve injury. But if you don't see one, is that because there wasn't a nerve injury, or like it gets hard? I don't know. At the end of the day, I end up treating them both fairly similarly. So,
yeah. I think we've pretty much covered everything that we wanted to. The only other thing I can think of is just a takeaway with regards to neuropathic pain in general is, right, it's actually not that hard to identify if you're asking the patient the right questions, but it can be a little bit difficult to treat as far as the responsiveness to the treatments that you want to give to a patient.
And I think that the term "little bit" is underselling it.
I'm trying to be nice.
You being our primary example on this podcast of neuropathic pain that's hard to treat.
I'm trying to be nice still. It's episode 3. I don't want to be too depressing. It's impossible. No one will respond. But just know you're lucky if you do. If you're not, there's nothing wrong with you.
Okay, and then just one thing there.
We'll have to go before I die.
If you do recognize that you got neuropathic pain, treat it early.
Treat it early. Right.
Like, and
it's in the bud.
I'll share my story on this and that. Yeah. Like I'm lucky because I have a knowledge base and I have access to therapies and I've got access to doctors because they're my mates. And so if I recognize that I've got neuropathic pain, I can get it treated early. Not so long ago while out on my bike, like I was riding my mountain bike in my mountain bike shorts, and like stupidly, these shorts just keep on tapping my knee. And I end up getting neuropathic pain because I've just hit this peripheral nerve however many thousands of times. Yeah. And I really annoyed it. And I was like, what is that? And after it, I'm like, it's flying off by itself. I'm touching it. I'm going, get out of town.
Dan immediately started crying.
I've got neuropathic pain from my bike shorts. I'm like, because I recognized it early and because I can, I was able to go, okay, it's neuropathic. I used some topical antineuropathics on it early, calmed it down a bit, didn't go away. And so what did I do? I injected it. I made it go away and it went away. Now, the difficult part of that, on the flip side, is that I had 2 patients at the same time that had pain in exactly the same area that had taken place due to slightly different injuries, they'd knocked that area of their knee, and it was horrendous for them. Yeah. And their pain was 2-3 years down the track, and so. That all of a sudden becomes really, really hard to treat because not only now have we got just a peripheral nerve injury, you've got, pain that's taking place at a nerve root, a spinal cord level. Yeah, you've got all the social stuff that goes around it. You've got the central sensitization that's going on. So we've gone
the positive feedback loop is on.
Yeah. And so I'm lucky. I can recognize the problem and I can treat it. And I think that if you recognize the problem, it's okay to treat it early. Get on with it.
Try to.
Try to.
All right. Got anything else?
Probably, but I think we should wrap it up. That'll do.
Save it for the next one. All right. Yeah. Thanks a lot for joining us. We certainly appreciate it, and we will see you next time. Take care.
Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.